Hello, everyone, and welcome. Good afternoon, good morning. My name is Heather White. I'm the Executive Director for Together for Health. I'm pleased to welcome you to the next installment in Together's ongoing webinar series, which highlights important topic areas in global cervical cancer prevention and control. In today's webinar, we will hear from panelists on the status of global investments in cervical cancer prevention and control. To kick off the presentation, we'll hear from my colleague Tom Harmon from the Together team about the updated funding brief that we've compiled recently at Together for Health that looks at and tracks global investments in cervical cancer. We'll then hear from experts from Gavi, the Vaccine Alliance, who will provide an overview of their investments and commitments to HPV vaccination to date, and also from colleagues at Unitaid, who will share their insights on their cervical cancer portfolio. Finally, we'll open up our discussion for questions, and I encourage you to share your questions within the chat function. Before we begin, a few words regarding logistics. First, all attendees are on mute. Following the presentation, we'll have about 15 minutes for Q&A, and I'll moderate the session. If you have a question for any of the presenters, please do write it in the Q&A box. We'll do our best to get to those. If not, we'll follow up after the webinar. The webinar is being recorded and will be available on our website after the event. If you'd like to see the catalog of other webinars, please visit our website at togetherforhealth.org. And finally, if you're interested in hearing other topics in this field, please do let us know. We'd love to hear from you. At the end of the presentation, we'll post links on how you can get in touch with us directly. Great. So why don't we get started? Our first segment will highlight findings from Together's recent report on global investments for cervical cancer prevention. The report summarizes estimated funding for HPV vaccination and cervical cancer screen and treat programs in low-income countries and low-middle-income countries for 2019 and highlights contributions from global actors to support the WHO's global cervical cancer elimination strategy. We hope that these data can assist global health leaders and policymakers in making the case for additional investments that will be necessary to achieve the 2030 targets outlined in the WHO's Global Cervical Cancer Elimination Strategy. To share this presentation, I'm very pleased to welcome my colleague, Tom Harmon, who will present on the findings from Together's report. Tom is an external affairs specialist at Together who led on the research and development of the report. In addition to his work with us at Together, his recent work also includes the creation of policy research and advocacy content for the Global Health Advocacy Incubator and strategic support for the Minnesota Brain Aging Research Collaborative. As a former staffer at the International AIDS Vaccine Initiative, Tom was instrumental in building the evidence base to catalyze political and financial support for HIV vaccine research. And with that, I hand it over to my colleague, Tom Harmon. Thank you.
Thanks, Heather. Can you guys hear me?
Yes.
Fantastic. So thanks for the intro, Heather. Just to say, this data report was born out of our desire to document and track global investments in global cervical cancer prevention in low and lower middle income countries. Next slide, please. So it's our second annual report and highlights, to the best of our knowledge, the portfolio of investments into primary and secondary prevention programs globally. This data is a combination of publicly available sources and data provided by organizations themselves. I should take this moment to thank Unitaid and Gavi for providing numbers for this report. And as Heather noted, it's solely focused on HPV vaccination programs and cervical cancer screen and treat. This does not include treatment for invasive cervical cancer or investments in new cervical cancer prevention modalities, so not research and development. The latter is actually compiled by Policy Cures Research as part of their GFinder project tracking investments into new sexual and reproductive health tools. Just a quick note that this is Probably not a 100% full data set. We know there's probably some more data out there, and I'd be thrilled to be corrected, provided I can be helpfully connected to some sources. So if anybody on this webinar sees anything that's missing, please do get in touch. We're still building this as it goes. Next slide. So our first slide here shows year-to-year investments in HPV vaccination programs in low-income and lower middle-income countries. One of the benefits of getting data for the second year in a row is that we start to get a sense of funding trends, hopefully. This chart shows total funding for those vaccination programs. One second. As you probably predict, funders of Gavi, the Vaccine Alliance, are the primary source for HPV vaccination programs in LICs and LMICs, and a year-on-year increase by Gavi to HPV vaccination represents the major driver of a 61.5% increase in funding, total funding, between 2018 and 2019. Also worth noting that co-financing by Gavi countries also increased pretty proportionally between 2018 and 2019. Next slide. Just a brief look at the 2019 data so you can see the amounts. I'll leave this up for just a bit, but you can also find these figures in the report referenced on the slide. We'll also have these slides up on Together's website in the near future if anyone wants to take a look or has any other use of these. Next slide. Here's a look at year-to-year trends in funding for cervical cancer screen and treat in LICs and LMICs. I'm sure you'll note the very dramatic increase, almost 1.5 times higher between 2018 and 2019. This was driven by 4 major streams. First, the large increase in funding through the PEPFAR-led Go Further program, which provides screening for HIV-positive women in 8 target countries in sub-Saharan Africa. That's actually going to be expanding to a total of 12 countries in coming years, so we may anticipate some further growth in that area from PEPFAR. The second I want to note is new funding from Unitaid. That's the dark purple bar on the right. Through their collaborations with the Clinton Health Access Initiative and Expertise France, respectively. I suspect we'll be hearing some more about that in just a few moments. The third stream is USAID's initial funding through their PEER program toward integrating screen and treat into family planning programs in Malawi and Mozambique. So that is the light blue bar, which, as you can see, was not represented in 2018 because it hadn't started yet. And 4, you'll notice in the light purple bar, a 5-fold increase in funding through the Global Fund, who recently started accepting funding applications for the integration of cervical cancer screening programs into HIV services. Next slide. Again, just a quick look at the 2019 data so you can see the amounts. Again, these will be available, and I'm happy to answer any questions at the end of the webinar. Next slide. So just one last slide to put the amount of this funding in perspective. The WHO had estimated a total of $10.5 billion need to achieve the elimination strategy start between 2019 and 2030. This breaks down where they thought funding was going to need to go. Total funding in 2019 for these programs, so basically vaccination plus screen and treat, even after fantastic new commitments and massive increases, totaled 121.3 million. So that's just to say we're a long way off from meeting WHO's projected need, especially since WHO projected the need for heavily front-loaded increases in vaccination and capacity building in the early part of this 2019 to 2030 period. Of course, these projections were also made prior to the unprecedented global health emergency we're all living through, which will almost certainly impact funding for any number of global priorities. So we'll see where things shake out next year. We do plan on publishing our 3rd year of data by the end of 2021, and hopefully we'll get a better sense of trends after that. I think that is what I've got, but I'm happy to answer questions after all the other panelists are finished. Thanks so much.
Thank you, Tom. That was a great overview. And again, I want to just acknowledge your hard work and efforts on putting together the report. Okay, great. Our next segment will be from Unitaid. It is my pleasure to welcome Smilka de Lusigny, who oversees Unitaid's portfolio of molecular diagnostic and cervical cancer investments. with the most recent addition of COVID-19 diagnostics. Smilka has extensive experience in program management, diagnostic networks, and HIV prevention, treatment, and care. Originally from Serbia, she holds a master's degree in pharmacy and public health. In today's presentation, she will provide details on UnitAid's cervical cancer investments to address barriers and catalyze the market to support adoption of innovative tools and for improved cervical detection and treatment of the cervical cancer burden in low and middle income countries, with a particular focus on women living with HIV. Her presentation is entitled UnitAid's Investments in Cervical Cancer. And with that, I'll turn it over to you, Smilka.
Thanks so much, Heather, and it's really great to be here on behalf of UnitAid, and especially this week when we are highlighting a lot of these investments and the movement that is gaining the pace with the launch of the cervical cancer elimination strategy last November. And it is really very important to also reflect on some of the points that were presented previously in terms of both the current state of investments as well as some of the ways that we can collectively go for actually making that money that is available bring us even further than what we have now. And we are constantly working with WHO as well to fine tune some of the estimates based on the improvements in affordability of the tools. And that is exactly the focus of what UnitAid is trying to do, especially in the secondary prevention. And in the next slide, if you see, when we started scoping the work in the cervical cancer, taking us a little bit to the outside of the traditional three diseases that usually UnitAid has been involved in, which is HIV, TB, and malaria, we looked at the cervical cancer first and foremost as a co-infection, comorbidity, based off of also the vulnerability of women living with HIV to HPV infection, and then the probability of both retention of the infection and then mortality, increased mortality in this specific group of women. And when we were scoping different areas where we could be helpful as an organization that has a mandate and both mission, and the intention to introduce innovation in public health, really the secondary prevention came across as the niche where both the market has shown a lot of movements, but also the public health response seemed probably less effective and scalable to the appetite of the strategy, elimination strategy, that we were all preparing ourselves to support, and especially based on different methods that have been used and still are in use in low and middle income countries, such as the visual inspection with acetic acid, and also the use of cryotherapy and ill-adapted treatment devices for treatment of precancerous lesions. So if you see in the next slide, our investments really focused on that niche, on screening and treatment of precancerous lesions. And currently we are, and I can't wait to see the slides, the bars for the 2020, but we are the largest funder of innovative tools to find and treat precancerous lesions in women living in low resource settings. And in 2019, we have committed in total of $60 million to get us through 2022 to cover diverse geography and with the mix of implementing partners, and we already spoke about CHAI and Expertise France, but we are also working with JPIGO, UICC, and we are also supporting WHO in their rollout of the elimination strategy. And the country scope is broad, and we try to reflect different geographies, but you can see that most of these countries are in Africa, and this is because our first intention was to work through the lens of co-infection and comorbidity. So where that kind of both disease burden and mortality is the highest. We are currently on target to reach 1 million women in 3 years with these innovations, and to save around 100,000 lives over during our investments and in the next 5 years after. We are focused on molecular tests, so introduction of molecular tests for screening for HPV infection. With or without self-collection kits. So we're trying to see both approaches of self-collection, but also healthcare provider assisted sampling. We are looking at really innovation in artificial intelligence as support for screening. I will speak about that a little bit later more. And then in the treatment area, really we're looking at a small, portable, battery-operated thermal ablation devices, and also some improvement in the LEAP piece. So if you see in the next slide, our approach is really in 5 different areas because that the innovation that we are seeing requires so many different aspects to be resolved. So first and foremost, we are really attempting to build an evidence base around benefits, harms, and cost effectiveness of different screening and treatment tools and algorithms. So that is where also the diversity of different countries and different contexts comes into play. We're trying to demonstrate how these tools can be deployed and then used efficiently across different settings. Then we're trying to also really come up with different service delivery models. And I will talk about them a little bit later, mainly looking at a variety of also HPV tests that could be deployed and how they can be deployed, but also which treatment thermal ablation devices could be used in what settings, etc. So country contextualization of different service delivery models. The next area is really to try and understand what would be the best ways to engage with communities and generate demand. And here we're trying to do that not only in the specific subset of women living with HIV, but really also to tackle how do we best reach out also to the general population of women. And especially, I must say, this has gained a lot of importance under the COVID conditions that were basically marking almost the whole year last year. So a lot of innovation came there as well in terms of how to generate the demand under pandemic conditions. The fourth area is really scalability, and I want to emphasize that we are not funding projects. Unitaid is funding national programs, and we are funding them in a way of resolving the different questions that the national program would have in order to apply the innovation that we are introducing at the national scale. So we are coming into these investments with the scalability agenda to it, so that basically the national programs are supported up until that piece of planning comes to the national scale. And then finally, and probably most importantly in some aspects, there is this area of improving affordability of screening tools and really establishing sustainable supply. When we entered into this, and I'll speak actually about it in the next slide, some of the operational considerations that we had to resolve, and that's actually the next slide, Sarah, if you can already move to. I wanted to zoom in, and it's related to the previous area 5 that I spoke about, but the HPV testing and thermal ablation and LEAP devices is the innovation focus, at least in the first years of our investments. And the cost and the deployment were the key questions that we really wanted to resolve. And we started with something, you start in the field where VIA is a not relatively cheap, but a very cheap intervention that is practically very difficult to compete with if you look solely at its cost, but not its effectiveness. So basically, we have started working with molecular diagnosis of an HPV virus, and frankly, already it was difficult to imagine that we will ever bring these tests down to the cost parity with VIA. However, we approached it from another angle and really looked into how we can at least reduce the prices to a much better levels than where we started. So the HPV testing prices, after our initial work with CHAI and reaching a lot of different agreements with suppliers, we have already managed to reduce them down by a third and achieve a price of median price of $9. Still, a lot of improvement could be made there, and we are now also looking at some of the efficiencies of also cross-disease use of these platforms. Thermal ablation devices are now available for less than $900 per device, which represents an average price reduction of 50%. And it's really interesting already that we are getting the field data, which indicates that treating a woman with thermal ablation devices with these new prices can be up to 10 times cheaper than cryotherapy. In terms of deployment, and I wanted to highlight this especially because of the audience of this webinar, there are so many also questions to be resolved, and so many different approaches that we have been trying out together with national governments based on what makes the most sense for them. But really, the technology selection for the HPV testing and then integration in national diagnostic networks was at the core of this. And we have been, there is a mantra that is being told in the cervical cancer space, that the screen and treat is at the same visit is the way to go. However, we need to look into whether this is really a necessary way to go in terms of whether we can improve some of the approaches to maybe still be able to make a woman return for the result or deliver that result otherwise, while we not necessarily use the testing on site, but use a larger network that might be even cheaper to use in the long run. So looking into the centralized high throughput technologies which come at lower price, but not with the same visit results return. And then on the thermal ablation LEAP devices and auxiliary equipment, we are really trying to resolve on the whole kind of procurement and supply chain piece, starting with quantification, starting how we procure and work with 2 suppliers that are relatively new to the market, but very keen and to deliver on a large scale. And then also to really set up systems for post-market surveillance for these devices. We have seen a lot of cryotherapy devices sitting idle in the field, non-functional, and we definitely want to avoid this with TA and LEAP devices that are going to be introduced, and especially from the both perspective of continuous services, but also the continuous product improvement. And finally, then on the next slide, I wanted to share a couple of thoughts on moving forward, and maybe during the discussion we will also still have some time to dedicate to these thoughts. But I have already emphasized, and especially in COVID times, we should continue to emphasize that the response has to be affordable. in order to make this an incremental investments. And we can do that because there are many programs and many investments already in whether it's in women health or in vaccination programs or in reproductive health services, but also in HIV and TB, which can be used and built upon in order to introduce cervical cancer. And especially we see that in the diagnostic systems that are in place that are now also being used for COVID, but that can incorporate easily also HPV testing. And of course, there needs to be further work on the pricing and affordability of key products. That piece has not yet been resolved completely. Then we need to understand and build the health financing for cervical cancer. And we are already seeing, even before COVID, we have seen the flattening budgets for HIV, TB, and malaria response. Now we're bringing yet another disease area and seeking financing for that. And then comes COVID on the top of that. So really resolving that piece will be very important and it should be an immediate focus for everyone. Then we need to resolve the demand side. I have already spoken about it a little bit. It is not probably reaching out to women living with HIV will be an easier task because they are already in the system and they are already receiving care for one condition. But getting to the general population and getting that in a way that is going to be continuous is going to be a challenge, especially also because we should be reaching the most vulnerable women who usually fall through the cracks for any disease intervention. And finally, and I guess everybody's today speaking, it's an unavoidable topic. We need to move forward in the COVID-19 pandemic reality. We need to restart the secondary prevention services. We have seen in many of our countries that because this is a preventive effort and because it was less urgent, that many countries prioritize some other services, especially in the peak of the COVID waves. And innovation today really allows for either remote or shorter visits. We have spoken about self-sampling. It can be in communities or in clinics, mHealth solutions to reach women and communicate different issues to women, but also thermal ablation devices that actually shorten the procedure time to less than 5 minutes versus 15 minutes with cryotherapy. So the innovation could serve also to resolve some of the new realities that COVID is imposing on us in terms of how we deliver care. I'll stop here. Many thanks for listening to the presentation, and of course I will be happy to respond to any questions during the discussion period. Thank you.
Thank you, Smilka. Those were really fantastic insights and remarks, and looking forward to the Q&A session and diving in a bit more deeply on some of the points that you've raised. I just want to remind folks, if you have a question for Smilka or for our colleagues from Gavi, please do share them in the chat function or in the Q&A box, and we will get to those. Fantastic. Next, I'm very pleased to welcome our next speaker, Dr. Anissa Sidibe from Gavi. Anissa is a senior program manager for HPV vaccine at Gavi, the Vaccine Alliance. She holds a Master's of Science in Bioengineering from Imperial College, a PhD in molecular, in molecular biology from King's College, and a Master's of Public Health from the London School of Hygiene and Tropical Medicine. Her previous experience includes work with the Global TB Program at the WHO, also as a program manager at Novartis, focusing on work in South Africa and Nigeria, and as head of laboratory at the Fondation Congolaise pour la Recherche Médicale in the Republic of Congo, and as a clinical research coordinator at the Center for Vaccine Development in Mali. Dr. Sidibe has authored numerous scientific articles across many infectious disease areas in peer-reviewed journals. Today, she'll present on Gavi's global commitment to increase uptake of HPV vaccine in lower-income countries. She'll share details of Gavi's market-shaping efforts to make this life-saving intervention more accessible and affordable, and share an overview of the program coverage to date, including challenges and disruptions from COVID-19, as well as opportunities for HPV vaccine integration within primary healthcare services. Her presentation is titled Accelerating HPV Vaccine Introductions in Low and Middle Income Countries to Reduce Cervical Cancer Burden. And with that, I'll hand it over to you, Anissa. Thank you.
Thank you, Heather, and good afternoon, good morning to everyone. And on the behalf of Gavi, we'd really like to thank the organizers for giving us an opportunity to present the Gavi HPV vaccine program. So the Gavi Alliance, for those who don't know about the Alliance, has as a mission to provide access to new and underutilized vaccines in low and middle income countries, and works really closely as an alliance with our partners who have a foot on the ground from WHO, UNICEF, JPIDO, UNFPA, to name a few, CHI, and also with manufacturers to ensure that these vaccines are accessible at a low price and an affordable price for low and middle income countries. Next slide, please. Within the HPV vaccine program, this map highlights the Gavi eligible countries, which you can see with the different bubbles and the cervical cancer death. And as what strikes here in this map is that a lot of the cervical cancer deaths are really in low income countries, which are also Gavi eligible, low and middle, I would say, are also Gavi eligible countries. And in green, we see in 2019, the programs in these countries that had HPV vaccine rolled out. So really highlighting a little bit of the equity gap across both geography, income, and disease burden in low-income countries versus high-income countries. Just to contextualize that 87% of deaths from cervical cancer are really occurring in low and middle income countries. Next slide. Given this equity gap, and together with manufacturers, with our market shaping team, in 2011, 2012, we were able to successfully negotiate price reduction and access to HPV vaccine at a price of $4.50 for Gavi eligible countries. So most of the low income and lower and middle income countries. Noting that the price in high income countries at the time that this was negotiated was about $100. So this was a successful achievement across the alliance with manufacturers and with partners to make sure that this life-saving intervention was accessible to the lower income countries. Next slide. So a little bit about the HPV program, and I think, you know, a date to keep in mind is 2016. I would say this is around the time that we really accelerated introductions and coverage scale up across low-income countries. The first years between 2011 to 2016 were really about learning and gathering lessons learned on HPV vaccination and whether this vaccine could actually be delivered in low-income countries, given the experiences of high-income countries, a lot of issues around hesitancy, around non-infant vaccination, and this unique population to be reached with 2 doses. So a lot of our focus in the earlier days was around vaccinating about 15,000 girls and collecting pilots and lessons learned. After which in 2016, we had a major revamp of the program, which has been focusing between 2016 to 2020 on accelerating national introductions with the aim of reaching 40 million girls by 2020. Next slide. At the time at which we reviewed all our lessons learned from the demonstration programs, I think there was in total 30 demonstration programs, was also the time where SAGE reviewed different vaccination strategies to accelerate the impact of HPV vaccination. And among those strategies, what was put forward by the SAGE was that we could reach a higher coverage and we could have more impact if we vaccinated more than one cohort and multi-age cohorts between girls between 9 to 14 years old. That those girls also had a little bit of cost effectiveness in the sense that they would only require 2 doses compared to the older ages, and the sexual debut in low-income countries, which started around 15 years, which would require 3 doses. So taking this into account, we also brought forward this strategy to our board. Next slide. So the board approved in 2016, 2017, along with the program changes, which was to move up rapidly from low scale and accelerating national scale up to invest in, to increase its investment in HPV vaccine program. So what you see here is that the routine cohorts, or if you want the single cohort and the girls which will be vaccinated year on year, as part of the national program, received vaccine introduction grants, which is a cash grant of $2.40 per target girl, just to support the introduction phase, and co-financing of the vaccine depending on their GNI. Gavi eligible countries co-finance a little bit of the vaccine. So most of our low-income countries only co-finance about 20 cents out of that $4.50. And of course, also, what the board approved is that for the additional cohorts to be vaccinated, there would be no co-financing. So it would be 100% supported by Gavi funds. And we would also provide operational costs to reach all these girls, basically making up a little bit of the lost years that we had with the demonstration program, and in line with the new strategic agendas of accelerating and moving towards elimination of cervical cancer. So this was a little bit around the financial support that countries get via the Gavi's HPV program. So cash grants for implementation support and operational support, and also free vaccines for multi-age cohort vaccination at no cost to the country. Next slide. So this is just, again, to come back to the earlier slide, to say that in 2012, 2016, we only had about 4 introduction in Gavi eligible countries, which are shaded in dark gray. And today we're pleased to say that we've moved forward with 21 country introductions. So we can see that the map is starting to be colored, and there is an acceleration of HPV vaccination across low-income and middle-income countries. And we have 10 more countries approved for vaccination, a total of 31 countries. All this between 2016 and 2020, so a mass acceleration. And we have below the list of the countries that have been approved and that have already introduced. So next slide. As we mentioned, the ramp up was very fast between 2016 and the previous years, moving from vaccinating 15,000 girls to trying to reach 6 age cohorts in one of the largest countries, which are Gavi eligible countries, from Ethiopia to Nigeria. So as we can imagine, the ramp up and the supply needs were accelerated also, and the demand was very huge compared to our previous years. So this map really shows the demand for just one cohort, which we call the routine demand, and the multi-age cohort, and what we have available as supply. Manufacturers, we've worked very closely with manufacturers to increase this production capacity. But again, as we can imagine, there was a big demand within 1 year. But we're happy to see that there's been commitments by different manufacturers to really increase their scale up, and also ensure that the prices for these vaccines remain very low and accessible to low-income countries. And what you see here is by 2024, 2025, we're really looking at closing the supply-demand gap with manufacturers. So the picture does look a lot better in the midterm and catching up a lot of the missed girls. Next slide. Also, to say that we are anticipating new manufacturers coming into the market in 2024, 2025. There's a list of some new manufacturers with WHO pre-qualifications in view, with the one moving ahead very fast, Innovax from China. So again, the demand has also brought a lot of attention and new manufacturers and new suppliers on the ground, which is really exciting for HPV vaccination across our countries. And again, manufacturers have continually committed even during our replenishment to increase the supply availability. And thanks to that, the program is moving very fast. Next slide. And again, this is just a slide to show that the HPV coverage in LMICs compared to HICs in terms of the first dose of the vaccine and the HPV vaccine, we're very happy of the successes that LMICs have shown, whereby the first dose is as high or even higher than some high-income countries. Where there's still a bit to do in terms of the program is really the dropout between the first dose and the second dose. And given the elimination targets of reaching 90% coverage, we're working very hard to move this coverage gaps forward. Next slide. So this is some examples of strategies that we've been able to develop in order to accelerate coverage. One is demand generation activities, as you can see here. Next slide. Identifying opportunities to integrate HPV with adolescent health, with HIV, with other services to increase the coverage and to reach our elimination targets for HPV vaccination. Next slide. CSO engagement. In India, we've had a project with SEWA, various CSOs in Uganda, again, all in hope to increase the coverage of HPV. Next slide. So the impact of COVID-19 vaccine on the HPV program, I think we to our surprise, and actually not to our surprise, but expected, a lot of the schools were closed due to the pandemic. So a lot of countries have really not been able to deliver their second dose, but we're really leveraging guidance from WHO to make sure that catch-ups are provided for these girls, and leveraging the 6 to 12 to 15 months interval time, knowing that the second dose can be given at a longer interval time than 6 months, and ensuring that countries can go back and vaccinate those girls that have missed their second dose. Next. Having said that, we've had really successful experiences, and again, showing the commitment that a lot of these countries have towards primary prevention and HPV vaccination. Laos was able to successfully introduce, reaching about a 90% coverage in May 2020, even with the lockdown, and changing some of their delivery strategy and thinking out of the box, such as vaccinating in communities, in health facilities, and being able to adapt quickly to the changing environment. Next. Likewise, Myanmar did all its introductions virtually, with a lot of YouTube training, virtual media briefings, teaching trainings for the teachers, and were able to reach a readiness of 93%, and in some of the regions, a high coverage such as 85%, and in others, a lower coverage. So again, this attests to the momentum and the commitment of countries to really push forward this intervention. So that's next, I think. Thank you very much, and I'll hand it back over to Sarah and Heather, and apologies for running a little bit over time. Thank you.
Thank you, Anissa. That was fantastic, and really appreciate that overview from your side at Gavi. Now we'll move into the Q&A session, and we'll have ask our panelists to take questions from the floor. It looks like we've got several questions that have come in from attendees, and I'll pass those along to our panelists. If others have questions, please do put them in the chat box. If I may, the first question I have is really for both of you. As we highlighted in our report from Together, and others have highlighted both in the conversation yesterday with UICC and JPIGO, for those who attended that that dialogue, as well as today's conversation. I wonder if you both could comment on what you all see as necessary and maybe opportunities, both at a national level, at a regional level, or at a global level, to sustain the coordination and the financing that is necessary to keep us moving towards the 2030 targets for elimination, recognizing that both UNAID and Gavi funding in many ways are considered to be market shaping, number one, and catalytic, number two. So how is it that we continue the financing and the coordination needed to sustain commitments towards the elimination targets? Smilka or Anissa, you're welcome to jump in. I don't know if one of you has comments.
Yeah, no, thanks, Heather. Maybe I can just try to maybe share some thoughts. I don't think that we definitely don't have responses now. There is the whole health financing team, also at WHO, that is looking at both costing and modeling, and as I said, refining models based on new costing data for different tools and different approaches, and then also supporting countries to build the investment cases. And even at the launch of the strategy in November, there were several investment cases that were released for several countries. I would definitely not say that we have cracked this, especially in the absence of first and foremost, it's a difference to other diseases where the specific funding mechanisms were created to support that, like HIV, TB, and malaria. And before COVID, a lot of attention to the elimination agenda in cervical cancer was on domestic financing, and we really need to collectively continue that analysis of both the financing needs, but also financing opportunities through the lens of what the COVID economic impact of COVID has done to that agenda of relying mostly on domestic financing for cancer, and then for cervical cancer under that. So I would say that there is a need of exactly what you emphasized, first and foremost coordination, and then sustaining at least the funding a little bit longer from external sources before switching to the domestic financing. And we will probably, due to COVID and due to that kind of financing gap, see a little bit slower uptake on the national scale of this. And maybe Anissa can also add in terms of the co-financing that is expected to be done for recipients of Gavi, and how that looks like. But definitely an important topic. And just to add that there were a couple of questions to that point in the chat, which were asking around our own financing, Unitaid's financing, and whether we will be continuing that. And I have to say that our intention is to work on a second wave of, or to think about second wave of investments that would build exactly on that kind of analysis of the financing needs, on kind of the speed for sustainability of secondary prevention with the foreseen domestic financing, and whether there are other technologies that we would like to also look into. So we are currently looking at that, but definitely have not yet firmly decided how that kind of second wave of investment will look like. But we are aware that definitely there needs to be something additionally done in this space, at least by us as one of the stakeholders investing in cervical cancer.
Thank you so much, Milka, for those remarks. And I realize that was a pretty substantive question to lay at your feet, so I appreciate you taking it on. Anissa, do you have other thoughts or comments that you'd like to share from your side?
Maybe to complement and add to Smilka's, I think at the global level, a lot, given the state of the pandemic, a lot of advocacy and momentum building to maintain what we've achieved so far, and ensure that it continues in terms of cervical cancer and investments, both at the country level and at the global level, in terms of policies, also development, to see how, for example, in the case of HPV vaccine, how to deliver this vaccine, given the challenges of the pandemic, the school closures, and so forth. At the country level, there will be several challenges and priority shifts with the COVID-19 vaccine deployment, but also seeing how we can leverage that opportunity to create more demand for immunization and vaccination and primary prevention to also increase our coverage. So just a few thoughts on that aspect. Thank you.
Thank you, Anissa. That's great, and I agree with you. I was hoping you would touch on, excuse me, the issue of really seeing opportunities in some ways about the fact that there are many more conversations and obviously eyes on how the COVID vaccine will work and what that rollout will look like, but how that will influence and affect the vaccine schedule writ large. I want to take a moment. We've had a couple of questions in the chat, and just ask you again both, what strategies, what opportunities do you all see around mHealth and around digital health related to not only reaching in terms of demand creation and informing consumers, but also perhaps pivoting to a more digital-based strategy around telehealth or tele mentoring for healthcare providers with respect to cervical cancer prevention. I'm just wondering if you all could share any insights that you may have around how mHealth has also influenced strategies this past year, given the COVID pandemic and lockdowns, or just speaking about mHealth strategies that you all may be looking at or evaluating more broadly. I don't know who would like to take the question first, but it's over to either one of you to give thoughts. Thank you.
I mean, I can jump in very quickly to say, and yeah, there are definitely a few comments both in the chat and then in the QA. And I like the statement that mHealth is an important strategy to accelerate the achievement of 2030 targets, and fully in agreement. We have looked into, so mHealth is the component of all our investments, and whether it's used for simply for patient navigation or for management of data and connection to health management, information management systems, or what we are currently looking at is or even just during COVID, we have used digital platforms to even just train providers and move the agenda of trainings at least further in the kind of physical distancing context. One of the kind of let's say extreme from the perspective of innovation angles that we are looking at mHealth or digital health solutions for cervical cancer is really the artificial intelligence based solutions for assisting with screening and diagnosis of cervical cancer or lesions on the cervix. And this is the collaboration that we have with the Global Health Labs, National Cancer Institute of the US, CHAI, and ourselves jointly looking into an algorithm that will actually be able to recognize and identify different types of lesions on the cervix and assist in that diagnosis and consequent care. And what we are hoping that with this innovation, we will actually, this will be the revolutionary one that will bring us to potentially what we are estimating a $1 cost of test and treat approach for women in the cervical cancer. So that's one pathway that we are exploring and hopefully will be successful in, but definitely in different aspects of just management of different steps of both information to providers, information to women, but then also managing that kind of continuum of care, including the screening, including then the results management and the connection to the treatment options. It is where the mHealth and of course the whole system of data management at the national level. So different mHealth solutions that we are looking there are really the ones and priorities given to the ones that can be integrated in whatever already exists in the country. So that there is an incremental investment there, and that the sustainability of it actually is higher than if we would go to standalone approaches. And we are looking at some standalone approaches, but again, from the perspective of something that will have to be there to stay there and to actually be used beyond the grants and beyond these investments. I hope that was clear enough, or I mean, it's something that can be a specific webinar topic in itself.
Sure. Yeah, agreed. It encompasses a lot of different elements for sure. We're running quickly out of time, but Anissa, I want to just give you a moment to make any final comments or perspectives around mHealth solutions and how they would apply to Gavi's work.
Thanks, Heather. So a lot of our work that has been conducted on mHealth has really been at the country level, and more specifically on the HPV programs, been really to cover that gap between the dropouts between the first dose and the second dose, leveraging reminding systems, reminders, tracking system, callback system for girls to come and get their second dose. And this will become even more important given, as I mentioned, with the COVID-19 and interruption of school-based vaccination and so forth. Another one has been in terms of actually having registers for HPV vaccination for especially out-of-school girls. And again, all in efforts to really identify, localize where are these under immunized, lower HPV coverage girls throughout at the national level, and being able to have more targeted approach to some of those more vulnerable groups, including the coverage of HIV positive girls with 3 doses of HPV vaccines. So a lot of work on that front, all in the objective to increase our coverage and try to achieve that 90% coverage that's being set out as part of the elimination targets. Thank you.
Great, fantastic. On behalf of the Together team, I want to thank you both and thank everyone for joining. And we appreciate that you've stayed on with us. We went just a bit over this today, so thank you all for staying on. Our sincere thanks to our colleagues from Gavi and Unit Aid. And may I remind you that next Thursday, February 4th, World Cancer Day, Together we'll be hosting another webinar to talk specifically about our colleagues in Botswana and their work around thermal ablation. We'll have representation from the Ministry of Health and from our colleagues at JPIGO to talk about their pilot and how they see thermal ablation integrated into their national cervical cancer screening and treatment program. So please join us for that webinar next Thursday. And again, thank you all so much for joining this afternoon. Good afternoon, good evening, and we'll see you again next time. Thank you all.
Thank you. Bye.
Thank you.